This recorded lecture will be going over Chapter 27, the gastrointestinal system, in the MedSurg textbook. The organs of the gastrointestinal or GI system are the mouth, pharynx, esophagus, stomach, small intestine, large intestine, rectum, and anus. The accessory organs are the liver, gallbladder, and pancreas. The appendix is attached to the cecum and has no known function in the digestive process. The walls of the digestive tract have four layers: the mucosa, submucosa, muscular layer, and a serous layer called the serosa. The teeth and tongue are instrumental in the chewing or mastication process. They help break down food into smaller pieces that can be acted on by various enzymes. Food moves from the mouth through the pharynx and down through the esophagus through peristaltis. These are wave-like motions of involuntary muscles within the walls of the organs. They move to the stomach, where mixing movements occur. Mucus, hydrochloric acid, intrinsic factor, pepsinogen, and gastrin are all secreted into the stomach from cells within its walls, and are then mixed into the food to break down further the particles for absorption. The mixture of partially digested semi-liquid food is called chyme. Substances are moved along the intestinal tract by the peristaltic action of the intestinal smooth muscle. The large intestine reabsorbs water and electrolytes, formulates some vitamin K, and eliminates waste products. The gastrocolic reflex initiates elimination. It is stimulated by the ingestion of food. By tightening the voluntary anal sphincter, the reflex emptying of the rectum can be stopped. The intestine is lined with various receptors that interact with the nervous and endocrine systems. These mechanisms will help control the release of digestive hormones and enzymes, as well as initiating peristaltis. The esophageal sphincter becomes less efficient at opening and closing, and the risk for aspiration increases. After age 70, the parietal cells in the stomach decrease their secretion of hydrochloric acid. Enzyme and intrinsic factor secretion will also decrease. The lack of intrinsic factor can cause pernicious anemia. The portal vein transports all venous blood and nutrients absorbed from the small intestine to the liver. The gallbladder connects to the common bile duct that leads from the liver to the duodenum. The gallbladder can store up to 50 milliliters of bile. The liver manufactures and secretes bile and bile salts necessary to digest fat and fat-soluble vitamins. The liver is a storage area for glucose in the form of glycogen, vitamins A, D, E, and K, and B12, as well as iron. The liver is responsible for how drugs are metabolized. The liver detoxifies and breaks down many compounds and drugs. The liver plays key roles in lipid metabolism, breaking down fatty acids and synthesizing cholesterol and phospholipids, and in converting excess carbohydrates and proteins into fats. The liver may store between 200 and 400 milliliters of blood. The liver synthesizes the prothrombin needed for normal blood clotting. The major pancreatic enzymes are amylase, protease, trypsin, and lipase. These enzymes are all essential to the digestion and absorption of nutrients from the small intestine. Gallstone incidence is higher in older adults, possibly because of an increase in biliary cholesterol related to diet and a tendency towards dehydration. The transfer of nutrients from the intestine into the blood is known as absorption. Metabolism is the sum of many physical and chemical processes of the absorbed nutrients. Metabolic activities involve the synthesis of substances needed to build, maintain, and repair body tissues, known as anabolism. Metabolism is also responsible for the breakdown of larger molecules into smaller molecules so that energy is available, known as catabolism. The GI tract is subject to infection, inflammation, physical and chemical trauma, and structural defects. An intestinal tract problem can be caused by blockage of movement of food through the intestine, known as an intestinal obstruction. Postoperative adhesions can sometimes cause an intestinal obstruction. Adhesions are bands of scar tissue that bind together two anatomic surfaces that are typically separate. Continued irritation and inflammation of the GI mucosa can lead to intestinal bleeding and to increased peristalsis, leading to inadequate absorption of nutrients. The stress response can also cause excessive GI secretions and decrease perfusion to these organs. Excessive stimulation of the digestive acid and enzymes can lead to a breakdown in the integrity of the mucous membrane that lines the digestive tract. The damage to the mucous membrane can result in gastric or duodenal ulcers or chronic colitis. Some disorders, like Crohn's disease and ulcerative colitis, are correlated with a genetic predisposition. Certain forms of colon cancer have been identified as having a genetic link, and there is a familial tendency for the occurrence of colon cancer. Lactose intolerance, which is common among older adults, can cause continuous diarrhea and malabsorption. Consuming sufficient bulk in the diet will help maintain a healthy colon by enhancing the passage of waste. Maintaining hydration can prevent constipation by helping to keep the stool moist. Heeding the need to defecate promptly will aid in keeping the gastrocolic reflex functioning well and can also prevent constipation and hemorrhoids. Decreasing mobility in older adults will often lead to digestive problems. Therefore, ambulation should be encouraged. Maintaining body weight within normal limits can help prevent hiatal hernia and esophageal reflux. Mechanical and chemical irritants that produce inflammation can often be identified by elimination diets to determine the foods that are causing the GI upset. Following the general rules of good hygiene and sanitation can prevent many infectious GI events. This includes washing the hands before cooking and eating, and cleaning cooking utensils and eating utensils properly. Gallstones can lodge in the common bile duct, leading to obstruction to the flow of bile. Women will develop gallstones more frequently than men. The incidence increases with age, obesity, and having several children because pregnancy can cause stasis of bile. Gallbladder disease tends to run in families, and it appears there may be a genetic link. On page 646, see the blue cultural considerations box about genetic gallstone risk. Native Americans secrete high levels of cholesterol in their bile. Most Native American men have gallstones by the age of 60 years, and 70% of the women in the Pima Indians in Arizona have gallstones by age 30 years. Mexican Americans of both sexes and all ages also have high rates of gallstones. Maintaining a normal body weight, eating a low fat, low cholesterol, high fiber, high calcium diet, avoiding rapid weight loss diets, consuming alcohol moderately, and maintaining an active lifestyle can all help prevent gallstones. Hepatitis B and C are causes of liver cancer in 70% of cases. Successful treatment of viral hepatitis can decrease but not eliminate the cancer risk. Many drugs and chemicals are toxic to the liver, and nurses should always be aware of the drugs their patients are taking that could lead to liver damage. Alcohol and other toxic substances are major factors in the development of cirrhosis of the liver. The liver is resilient, and it can regenerate if part of the liver remains functional and if bleeding has been stopped quickly. Most parasites that damage the liver will enter the body when people wade or swim in contaminated water, typically in tropical countries, or eat contaminated food. Obtaining immunization against hepatitis A and hepatitis B can help prevent viral diseases. Avoiding exposure to known toxic or carcinogenic chemicals and drugs can also help prevent liver damage and liver cancer. On page 647, see the green health promotion box, preventing contraction of hepatitis. Practicing good hygiene and avoiding contact with substances that harbor the hepatitis virus, like raw oysters and shellfish from contaminated waters, can prevent infection with hepatitis A. Avoiding unprotected sex with people who are drug users or those known to be carriers of hepatitis B or C can also help prevent both the contraction of both types of those hepatitis. Pancreatitis is an inflammation of the pancreas. This is associated with alcoholism, obstructive cholelithiasis, peptic ulcers, hyperlipidemia, and trauma. Pancreatic cancer incidence will rise steadily with age. Obesity, chronic pancreatitis, and diabetes mellitus are also risk factors for this type of cancer. Avoiding consumption of large quantities of alcohol can prevent pancreatitis. Elevated triglycerides could also precipitate pancreatitis. Diagnostic tests for disorders of the intestinal tract and accessory organs consist of X-rays, CT scans, nuclear medicine scans, MRI, ultrasound studies, endoscopy, biopsy, laboratory test of gastric secretions, and stool and urine studies. The patient will often be scheduled for a series of tests, some of which may use a contrast medium. Always check the patient's allergies to verify that a particular contrast medium or injectable marker is not contraindicated. For women of childbearing age, a pregnancy test might be ordered. For screening, a yearly high-sensitivity fecal occult blood test or a fecal immunochemical test, known as a FIT test, could be recommended starting at age 45 years. The patient will need specific instructions about preparing for their diagnostic test. Many of these studies will require a cleansing of the GI tract. An inadequate bowel preparation could cause a delay or necessitate a repeat of the test. On page 648, see the red Older Adult Care Points box. Older adults are especially at risk for problems of electrolyte imbalance, fluid overload, or dehydration when preparing for diagnostic tests that require a fasting state and/or a bowel cleanse. Be sure to monitor for metabolic acidosis. Also on page 648, see the purple clinical cues. If a patient has trouble with nausea, having a few ice chips first and then using a straw to drink the solution for colon preparation can help decrease the taste sensation. Also on pages 648 and 648 going to page 653, within table 27.1, you can read about the different diagnostic tests for GI disorders, as there are very many of them. For many GI tests, the patient is kept on a nothing by mouth or NPO status the night before. A lack of oral intake can quickly dehydrate a patient who has already been ill with nausea, vomiting, or diarrhea. Ask questions about family history, diet, dietary intolerances, pain, bowel patterns, exposure to toxins and chemicals, and problems with blood clotting. Inspect the patient's teeth, gums, and oral mucosa for any obvious problems. Assess for the presence of edema and ascites. This is a fluid buildup in the abdominal cavity, by observing for any marked abdominal distension or any taut, glistening skin. Check the contour of the abdomen and note any outpouchings that could indicate a hernia. Perform auscultation before palpation or percussion, because palpitation can cause peristaltic movement that otherwise may not have occurred. Bowel sounds are caused by air and fluid moving throughout the intestinal tract, and they can be heard as soft gurgles and clicks every 5 to 15 seconds. The normal frequency for these sounds is about 5 to 30 in a 1-minute period. Loud, frequent sounds will occur when there is excessive motility in the bowel. On page 654, see the purple clinical cues box. For bowel sounds to be considered absent, it is necessary to verify that no sounds have been heard after listening in each of the 4 quadrants for a total of 5 minutes. Hypoactive bowel sounds could be noted in the medical record when no sounds are heard after listening in each of the 4 quadrants for 30 seconds. If hyperactive, high-pitched sounds are heard in one quadrant and decreased sounds are heard in another quadrant, assess the patient for nausea and vomiting because the patient could have an intestinal obstruction. Lightly palpate over each quadrant and watch the patient's face during palpation to detect any signs of discomfort. If a pulsating abdominal mass is present, do not perform palpation. This pulsation could signal an abdominal aneurysm with the potential danger of sudden rupture. Percussion can be performed by placing the middle finger of one hand on the abdomen and then striking the finger lightly below the knuckle while listening for the pitch of the sound produced. A resonant sound will be heard over areas filled with air, and a dull, thudding sound can be heard over solid organs. Percussion detects excessive air in the intestinal tract, which typically occurs with irritation and inflammation. Assess ascites by placing the patient supine and exposing the abdomen. With the patient's arms at their sides and their knees flexed, observe for any bulging flanks, indicating fluid accumulation. If ascites is present, measure the abdominal girth. Evaluate urine for the presence of any bilirubin, which could cause the urine to be dark or tea-colored. If undigested fat is present, the stool will float in the toilet bowl. If bile is not reaching the intestine, the stool will appear clay-colored or whitish. It is important to consider the time that it will take for toileting and cleaning up after loose bowel movements. All nurses must ask patients every day about their bowel movements to prevent constipation and possible impaction while in the hospital setting. Ideally, the patient should demonstrate normalization of eating habits and bowel patterns. You should continually evaluate whether the patient is experiencing any adverse side effects of their therapy or complications from their disease process. Anorexia is the absence of appetite. Physical causes for a diminished interest in eating include poorly fitting dentures, stomatitis, decaying teeth, halitosis, and a bad taste in the mouth. Pain or nausea in the presence of a mouth or GI infection or irritation can also decrease the appetite. Appetite is stimulated by the sight, smell, and thought of food. Persistent anorexia must be addressed to prevent the consequences of inadequate nutrition. Nursing interventions include mouth care before each meal to eliminate or minimize oral causes of poor appetite. The percentage of each meal eaten should be noted and documented. If psychosocial or cultural factors are involved, you could try offering preferred foods if possible, if they're not detrimental to their health. You, a family member or friend, could provide companionship while the patient eats. Anytime a patient has continual problems with eating, a dental care history and an oral cavity examination should be performed. It is essential to explore each patient's cause of anorexia and their feelings about eating. Transient nausea will typically not be treated, but when the disorder persists, medications with antiemetics and administration of IV fluids will be necessary. Surgical intervention, mechanical obstruction, and accidental injury to the intestinal tract could all cause disturbances in the passage of gas and fecal material. Flatus or gas is formed by the action of the digestive juices and bacteria on the ingested material. It results in bloating. Assist the patient to ambulate. This has traditionally been the nursing intervention for sluggish peristaltis or bloating. The Trendelenburg position can be useful in speeding up the expulsion of gas. Place the buttocks and legs higher than the trunk and the head. This will cause gas to rise towards the rectum, making it easier to expel the flatus. Advise the patient to avoid chilled or hot drinks. These can create more gas. When constipation occurs, the stool is hard, dry, and difficult to pass. There may be a bloated feeling, and defecation can be painful. A diet low in fiber or inadequate fluid will predispose the patient to constipation. Opioid medications can also contribute to constipation by slowing peristaltis. In addition to not passing stool regularly, signs and symptoms of constipation include hypoactive bowel sounds, abdominal distension, a firm abdomen, and abdominal discomfort or pain. The first step is to identify the cause of the constipation. Initial treatment could include a rectal suppository or a laxative. A stool softener may be prescribed. Fiber and liquids will be increased in the diet. If the colon has become impacted with stool, digital extraction may be needed. Counsel the patient to add a lot of raw fruits and vegetables to their diet, to eat more whole grain cereals and breads, add bran to their diet, and drink plenty of fluids. Fruit juices can be particularly helpful because they contain fructose, a natural laxative. Mild diarrhea will not be treated. If diarrhea persists for more than 24 to 48 hours, or if the number of stools is so excessive that great quantities of fluids are being lost, treatment should begin. Antidiarrheal agents like Lamodal, Imodium, or Pegoric, or a combination product like Kaopectate can be administered. If the diarrhea is moderate, only clear liquid should be permitted by mouth. Then, as the condition improves, you can advance the diet. Monitor the patient for electrolyte imbalances and watch for any signs of dehydration, like decreased skin turgor, thick oral secretions, and a decreased urine output. Taking small amounts of an electrolyte replacement solution or Gatorade can help prevent these imbalances. When infection is the cause of the diarrhea, follow contact precautions to help prevent the spread of the infection. Antibiotics will kill harmful bacteria, but they also eliminate our normal intestinal flora. Patients taking antibiotics are at risk of developing a bacterial infection with Clostridium difficile, also known as C. diff. This can cause severe diarrhea. Keep the patient clean and dry is a high priority. Frequent loose bowel movements can cause rectal irritation. Instruct or assist the patient to apply a lubricant like an A&D ointment, Aquaphor, Desitin ointment, or petroleum jelly to protect the skin and promote comfort. Tracking the time of the incontinent movements and offering toileting after each meal every day can help eliminate problems of incontinence. Should incontinence be persistent, the cause should be identified and then a bowel training program be instituted. For bowel training, the patient should be in a private environment for 20 to 40 minutes after a meal, and they should assume a normal sitting position for defecation if possible, or a side-lying position if they are bedridden. You or the patient will perform digital stimulation by gently inserting and rotating a gloved, well-lubricated finger into the rectal sphincter. This action should be done on a regular basis to mimic the patient's normal bowel pattern. Consistency and patience are vital to the success of retraining the bowel. Reassure the patient that calling for help will ensure their safety and provide an opportunity to observe their progress of the training program.